about opioids. It's similar. Tolerance to intoxication happens quickly, right? And withdrawals are profound. So screening for opioid use, again, we're not detectives, but then again, sometimes the DEA thinks you should be. So it's important to remember some of these things. And yeah, if your patient wants their refill like now and is consistently early and they only can have this one drug, then you might be looking at someone who's abusing opioids. And that's the big deal in the news lately. Naturally, heroin is what it is, but I think the big bad that everybody's scared of now is oxycodone, hydrocodone, and everything is being prescribed by us, right? So we're the dealers, and we want to watch for this because patients work pretty hard to get their opiates. Signs of intoxication are pretty dramatic. Withdrawal, not too terribly medically dangerous, but as my mother used to always say about the flu, it won't kill you, but you'll wish it had. It's very, very, very miserable. Treatment for opioid use disorder, CBT, behavioral therapy, family therapy, again, 12-step programs. Relapse rates are abysmal. So you definitely need to be ready for kind of a chronic relapsing and remitting. Medication treatments are a little bit more broad. Naltrexone is on that first-line list. Just remember, sure, it may be a first-line treatment for opioid dependence, but as 80+% of you remembered, you don't give it to somebody who is still withdrawing or has any opiates on board. This drug blocks the effect of opiates, and they can have a bad day if we give them some naltrexone while they're still potentially having some opiates on board. So they do need to have a substantial portion of abstinence, maybe that sub-Q injection, tiny little trial to see if they're really ready. Methadone is replacement therapy. Buprenorphine is replacement therapy. So this is long-term withdrawals. Again, buprenorphine and methadone can certainly be helpful either as maintenance or as a taper. I don't know that taper is necessarily that helpful for the long-term outcome, but depending on the circumstances, maintenance may or may not be an option. Clonidine, it's on the list. I've never met an opiate addict that thinks that clonidine does anything, but okay. And then, Vistaril, hydroxyzine, Benadryl, sedative hypnotic to help with sleep. Sometimes folks are using Phenergan for the vomiting and so on and so on. So supportive care. Treatment setting, overdose, naturally the patient's got to be in an inpatient setting to keep them alive so that you can try to help them not relapse later. And then your treatment options are right there. Outpatients, where most of this happens, and in the outpatient setting, buprenorphine is certainly gaining a lot of speed. You need a waiver for that. Everybody got their waivers? All right. Not hard to get. And you'll see kind of what you need to know to get